All right, let's get right into it. Today we're breaking down one of the most vital tools in a clinician's toolbox, the arterial blood gas, or as you'll hear it called, the ABG. This is a procedure that gives you a direct window into a patient's respiratory and metabolic status. And really understanding it, it's a total game changer.
So just think about it for a second. When you're in a critical situation, how do you get an immediate, no-filter look at how your patient is actually handling oxygen, carbon dioxide, and their body's basic pH balance? Well, the answer is the ABG. It's like a direct message from the body's most important systems. So here's our game plan. First, we'll decode what an ABG even is and why it's so darn important. Then, we're going to walk through patient safety and prep. Super important stuff. After that, we get to the procedure itself, what I like to call the art of the puncture. Then we'll learn how to actually read the results, and we'll wrap it all up with the key things you've got to take away from this.
Okay, let's jump right into part 1, decoding the ABG. Look, before we even think about the how of this procedure, we absolutely need to nail down the why. This is the foundation for everything else we're going to talk about.
So the most important word is right there in the name, arterial blood. See, this isn't like your everyday blood draw from a vein. An ABG sample comes straight from an artery, which is carrying that oxygen-rich blood right from the heart and lungs. This gives us an incredibly pure, real-time picture of a patient's gas exchange and acid-base status. So what are we really looking for in the sample? Well, it boils down to 4 key players. First, there's the pH, which gives you the overall acid-base balance. Is the blood too acidic or too alkaline? Second, PaCO2, which tells you how well the lungs are getting rid of carbon dioxide. Third, PO2, showing how well they're getting oxygen into the blood. And finally, HCO3, or bicarbonate, which is all about the metabolic side of things managed by the kidneys. These values are absolutely essential, especially for guiding treatment for patients on ventilators. Moving on to our second section, let's talk about patient safety and preparation. This is where we figure out the who and, just as critically, the who not. Because doing this procedure safely, that's always priority number 1. So on the left, you've got your indications. These are the critical situations like respiratory failure, DKA, or sepsis where an ABG can be a lifesaver. But on the right, you've got the contraindications. And listen, these are your hard stops. If there's been surgery at the site, if the patient has a clotting issue, or if their collateral circulation is poor, you just have to find another site or another way. It's that simple. And this is exactly why we're so careful. You know the risks aren't super common when you do it right, but they are real. We're talking about things like hematomas or even thrombosis, nerve injury, or a nasty infection. That's why preparation and a precise technique are everything. Okay, so where are we going to do this puncture? Well, the radial artery in the wrist is the undisputed champion. It's our first choice because it's close to the surface, it's easy to find, and this is the big one, it has fantastic backup blood flow from the ulnar artery. The brachial and femoral arteries, yeah, they're backup options, but they're deeper and they come with a few more risks. And that brings us to section 3, the art of the puncture. This is our step-by-step guide, and it all kicks off with one of the most important safety checks in medicine. Before any needle gets anywhere near that radial artery, we have to perform the Allen's test. This is a simple check that confirms the ulnar artery can handle the blood supply to the hand, all on its own, just in case something happens to the radial artery. You just elevate the hand, squeeze both arteries at the wrist, and have the patient open up their hand. So let's picture what's happening. When you're pressing on both arteries, the palm turns pale or blanched, right? Because the blood flow is cut off. Now for the moment of truth. You let go of the pressure on the ulnar artery, but you keep holding down the radial. And here's the green light you're looking for. If you see that color rush back into the hand in about 5 to 10 seconds, that is a positive Allen's test. It means the ulnar artery is working perfectly, the collateral circulation is great, and you are officially safe to proceed with the puncture. So once you get that positive test, you're ready to rock. Clean the site really well, then stabilize the artery with your fingers. And here's the key part of the technique. You go in at a 45 to 60 degree angle with the needles opening, the bevel facing up. The pressure inside the artery is going to do all the work for you. You'll see an automatic flashback of bright red blood pop right into the syringe. And this slide gives you the perfect mental image. Just look at that angle of entry. See, it's not too steep, but it's not too shallow either. This lets you get into the artery cleanly without poking through the back wall, which is how you avoid a nasty hematoma. All right, we've got our sample. Now for the fun part, the detective work. It's time for section 4, turning all those numbers into an actual diagnosis.
First things first, you have to know what's normal. This table right here, this is your baseline, your source of truth. A pH between 7.35 and 7.45, PaCO2 between 35 and 45, and bicarb between 22 and 26. You've got to burn these numbers into your brain because everything else is based on them.
The very first value you look at every single time is the pH. It gives you the big picture. Is the blood acidic or is it alkaline? If it's below 7.35, you've got acidosis. If it's above 7.45, it's alkalosis. Simple as that. This tells you what the problem is. The next two values are going to tell you why.
Okay, next up, PCO2. Think of this one as your respiratory report card. Since we breathe out CO2, this value tells you how well the lungs are doing their job. If the CO2 is high, it's making the blood more acidic, which can cause respiratory acidosis. And finally, we've got HCO3, or bicarbonate. This is the metabolic piece of the puzzle. It's the kidney's job to manage bicarbonate to help balance the blood's pH. So if this number is out of whack, it's pointing to a metabolic issue as the cause of the problem.
Now let's put the pieces together with a little pattern recognition. Here's your first classic combo. If the pH is low, meaning acidosis, and your HCO3 is also low, then the problem is metabolic. See how they're both heading in the same direction? That's your clue for metabolic acidosis.
But what if the pH is low, and this time the PaCO2 is high? Now we have the respiratory pattern. When the pH and the CO2 are going in opposite directions, that tells you the lungs are the source of the problem. This is a textbook picture of respiratory acidosis. Okay, we have covered a ton of ground here, right? From the why to the how to the what does it all mean? So let's bring it all home with our fifth and final section, your critical takeaways. If you walk away remembering only 3 things, please make it these 3. 1, safety first. The Allen's test isn't optional. It is a non-negotiable safety check. 2, technique matters. A steady hand and that perfect angle are your best friends for preventing complications. And 3, when you're reading the results, think in 3s. pH tells you the problem, then CO2 and HCO3 tell you the cause. At the end of the day, an ABG is so much more than just a bunch of numbers on a screen. It's a fast, powerful tool that tells the real-time story of what's happening inside a patient at a really critical moment. It's not just a test, it's a story written in blood. The real question is, are you ready to read it?